Okay, so welcome everybody in this afternoon session about telecare and counselling. I think it's very important to use technologies during COVID times to improve communication, so stay in touch and also get support. And we have 5 speakers in this session who will talk about that subject. So Hannah, go ahead.
All right. Good afternoon, everybody. Thank you for the introduction, Franka. So welcome to my talk on financing the sustainable implementation of eHealth interventions for carers of people with dementia. I'll be talking about lessons we learned from looking at 9 case studies of interventions that are already being used in practice in the Netherlands. Excuse my voice, it might come and go a bit over the course of the talk. My name is Hannah Christie. I'm a postdoctoral researcher at the Alzheimer Center Limburg at Maastricht University. So as I'm sure you know, informal care is a crucial part of dementia care. And while there are some positive aspects to caregiving, such as a sense of purpose and an enriched bond, in some cases with the person with dementia, informal caregivers have also been shown to experience significant physical and psychological complaints as a result of this caregiving process. So given the fact that the prevalence of dementia is 50 million people worldwide at the moment, we expect it to triple by 2050, and healthcare systems are very reliant on informal care. It's very important that these informal carers of people with dementia are supported properly. So previous research has shown that eHealth interventions to support these carers, like ones we've talked about before, have been really effective in improving caregiver outcomes such as self-efficacy, competence, and knowledge about dementia, and also in reducing some symptoms such as depressive symptoms and anxiety. Moreover, eHealth can be easily personalized to the phase of dementia and the type of dementia, and potentially scaled up at quite an efficient cost, or an efficient way, and cost-efficient way. Moreover, now with COVID, eHealth provides opportunities to provide safe care at home for vulnerable populations. If you're wondering what I mean by eHealth, I have some examples. For instance, InLife is an app to organize dementia care, or Partner in Balance is an intervention that increases self-management capabilities in carers. Unfortunately, previous research has shown that only 3% of psychosocial interventions for dementia are actually implemented into practice. Likewise, my doctoral research showed a similar rate specifically for eHealth interventions for dementia. In addition to the eHealth interventions being developed in the academic research context, there is also eHealth being developed outside of academia, for instance, by industry and healthcare organizations. And there's much we can learn from these eHealth interventions that are already being used in practice to aid the implementation of evidence-based eHealth from the academic research context. A useful framework to explore the factors that contribute to financial sustainability of interventions is the business model canvas. It's an established framework to aid in the development and mapping of business models by looking at sort of the product or services, various components. So you see here the partners, activities, value propositions, revenue streams. I won't go into all of these aspects in detail today, but what was quite useful for this case study analysis was sort of splitting it up into these colored boxes you see of feasibility, desirability, and viability. So the study I'm talking about today had the following objectives: to examine a sample of case studies of eHealth interventions to support caregivers of people with dementia that are currently used in the Netherlands, to look at what strategies they use to ensure desirability, feasibility, and sustainability of the interventions, and to look at how we could learn from those interventions already being used in practice for the future development of our own eHealth interventions. So first, we sent emails with an invitation to provide examples of interventions meeting the criteria I just described. So used in practice, eHealth, useful for caregivers in the Netherlands. This is the sample that we ended up sending, or at least the people we ended up sending invitations to. So in total, that's 483 emails, and we got 66 reactions. In the end, 9 of the recommended interventions met our criteria. And I ended up calling representatives from these interventions and including them as a case study. So I did 9 telephone interviews with the developers of these interventions that were already used in practice and had been recommended by this sample of stakeholders. On average, the interviews lasted about 25 minutes. We looked at the business model together using the business model canvas, and we collected data on what type of intervention is it, how is it currently used, and sort of more details like this. So here you'll see the 9 case studies. I had to take some of the names out as the interview participants preferred this. In 4 cases, we found sort of sustainable business models, or what we called that. And by that, we meant that business models that generate revenue for the upkeep and development of the intervention in the future. And overall, 5 cases were sort of more exploratory and more dependent on research grants, but some of them also had preliminary business models. I'm not going to go into all the different business models we found, but I have the reference to the paper at the end of the presentation if anyone would like to read a bit more in detail. I'll be going into overall conclusions now. So the analysis of the interviews have led to sort of recommendations on how to achieve long-term implementation of eHealth for caregivers of people with dementia. Sort of leading to this core business model. And first I'll talk about the design, and that covers actually at first all 3 aspects of desirability, feasibility, and viability. So when we looked at, what makes these interventions desirable in a way that could lead to long-term implementation, it was the case study interview respondents mentioned that fitting within sort of existing organizational goals in a care context was very important. Secondly, looking at the feasibility, the case studies tend to supply sort of their own dementia specific content, but outsource IT and all sort of help desk related things externally. That does not own the content. So they're sort of 2 separate entities working together for one intervention. That seems to work quite well. And finally, the 3rd key element of this design was viability. And we saw that a sort of prevalent sustainable cost structure was a fixed price to be paid for the intervention for access. And that could be paid by caregivers, or more commonly actually by healthcare organizations. So a care home or something like this. It was also very beneficial, another viability for sustainability of this viability was integrating it into a larger platform. So no cost was charged to the caregiver. It was part of a larger service. So that's quite a lot in one go. But we also looked at who is doing this. And we saw what might not be very surprising is that case studies that did not originate in an academic research context more sustainably achieved long-term, or more successfully achieved sustainable implementation compared to the case studies that did originate in an academic context. What is that? And then finally, an important question was which strategies can help bring this proposed core business model into practice. And here we saw that community creation was very important. So interventions that really invested into their social media and in connecting users with each other did quite well in the long term. So really investing in that community feeling of your users. So I've come to my conclusions. Again, we saw that case studies that did not originate from an academic research context seem to achieve more sustainability, that it's very important to build user communities around the interventions. The proposed business model suggests increasing desirability, feasibility, and viability by integrating into larger existing structures, usually within a care organization or a national platform, by sort of owning and supporting dementia-specific content internally while developing ICT services externally and offering sort of fixed low-level pricing. So if we look at what can we learn from that for sort of research and academically developed interventions, what was very important was the so-called digital transformation strategies, which I talked about in sort of building communities, social media, building online user experiences where people can get to know each other through the intervention. That keeps people engaged. More intersectoral cooperation, so really looking at those collaborations with ICT partners that can help you get started business model wise and help you out with all the IT questions that always come up with an eHealth intervention. And finally, from a policy perspective, there's definitely a need based on the interviews we had for more financial incentives for research on sustainable business models. So looking at how can we bring that into research policy and make sure that people also have the funds, or researchers have the funds they need to get started in this way, and make sure that caregivers actually benefit from the eHealth interventions we develop in the research context. So that's what I had to say today. This is the reference to the publication if anyone would like to read a bit more. I'm happy to hear any questions either now or later via email or Twitter. So thank you very much for your attention.
Thank you, Hannah. It's just my my alarm is going now that the time's up. So, but I think you did a very nice study and went beyond what researchers usually do to do an effectiveness study. Also look into what might help in implementation or not. And you looked at interventions that were already in use and studied there what might help in further implementation. So thank you very much. I did not see questions from the audience, and I really would like to invite the audience to address your question in the Q&A that I hope you can see also. And I hope we have time at the end then to be able to answer your questions, and otherwise we can forward them to the speakers. So for now, thanks, Hannah, and I would like to go on with the next presentation. It's a presentation by Claudio Di Lorito from the UK, beautiful name. And he will talk about being physically active with a tele-rehab program. And Claudio has a pre-recorded video, so I would like to ask Vincent if you could bring that up. So we first see the video.
Good afternoon, and thank you for your attention. My presentation today is entitled Keeping Physically Active Through Tele-rehab During the COVID-19 Pandemic. Results from the Promoting Activity, Independence and Stability in Early Dementia study. So first up, I would like to thank my team at the University of Nottingham for their support. So the presentation today is going to be based on the following points. I'll give you a bit of an outline of today's session. So the first thing I would like to do is give you an introduction of PRAIST. I will pass then to discuss about the impact that the COVID-19 pandemic had on PRAIST, a little bit about the Lincolnshire team and eHealth, which this study is based on, and then I will describe the case study that I'm presenting this afternoon, and some implications for future clinical practice. At the end of the session, we'll be happy to take some of your questions. So a bit of background about PRAIST. PRAIST is an acronym that stands for Promoting Activity, Independence and Stability in Early Dementia. PRAIST is a program which delivers physical dual task exercises and functional activities of daily living to participants with dementia. Some of the examples of the activities that we're delivering through PRAIST are in the link below. PRAIST is intended to be delivered in participants' home by a multidisciplinary team made up of physiotherapists, occupational therapists, and rehabilitation support workers. PRAIST lasts a year. So these therapists go into the participant's home and co-develop with them and also with their carers a program, which includes physical activity and exercises, but they also set some goals to be achieved at the end of the 12-month involvement. The participants are then asked to follow the program independently in between the therapist's visits, which usually occur on a weekly or bi-weekly basis. These visits are intended to monitor the progress of participants and also to make adjustments if necessary. There's 2 links here about PRAIST, but also about the multi-site randomized control trial, which is currently evaluating the clinical and cost effectiveness of PRAIST. So in March 2020, the United Kingdom government started to implement some measures to slow down the spread of COVID-19. These measures lasted in the first instance until the end of summer in August 2020, and they had an impact on PRAIST, on the RCT, which was ongoing at the time. The measures mandated that people over 70 years of age and with pre-existing conditions, such as dementia, were required to stay at home to minimize contact with other people and only receive urgent health or social care visits at home. And PRAIST was not intended as urgent care. So we decided to convert delivery of PRAIST in order to continue with the trial from a face-to-face in-home visit to remote delivery of therapist visit sessions. We decided, therefore, to provide participants who were in receipt of PRAIST at the beginning of these governmental measures to convert these participants to a support either through the phone or through video calling. So the Lincolnshire Partnership National Health Service Foundation Trust is one of the 5 research sites in PRAIST. And when we converted PRAIST to a remote delivery, the whole team delivered the intervention through a video calling platform named eHealth. eHealth is an NHS-approved video calling platform, which again allowed the therapists and the participants to set up and attend their digital appointments entirely online during the pandemic. You can see on the screenshot on the right-hand side the interface that participants were presented with when accessing eHealth. eHealth required certain aspects to be able to enable the participants to use it. First off, it required an internet connection and also a computer, a tablet, or a smartphone, but also the ability to download the application, to book the digital session, and finally to connect for the session. So the Lincolnshire team developed a set of instructions to support participants to be able to install and use the eHealth. So this case study is entirely based on this sort of experiment of tele-rehab that the Lincolnshire team did during COVID-19 lockdown. The aim that we set out was to present some preliminary evidence on tele-rehabilitation with a population of people with dementia. The objectives were 2. The first one was to identify the type of clients that tele-rehab might work for, how it might work, and under which conditions. And the second objective was to identify some potential benefits and challenges. We carried out qualitative semi-structured interviews with 5 participants with dementia from the Lincolnshire catchment area, receiving praise through the eHealth during this lockdown period. The participants were interviewed together with their caregivers. But we also did some qualitative interviews with the therapist team delivering praise through eHealth. The interviews were conducted through conference calling at 2 different time points. Baseline was 1 month after starting using eHealth, and follow-up was 4 months after starting using eHealth. We analyzed the data through deductive thematic analysis, setting our study objectives as the main theme. The full text of this study is available online, is open access, so feel free to check it out for further info. Let's look at some of the results. So in terms of the conditions under which eHealth worked best, the participants reported that a necessary requirement was for someone to be present to facilitate the installation and the use of eHealth. Usually this was a carer, but regardless, it was one of those requirements that somebody acting as a facilitator would be present with the participant with dementia to be able to use the technology. Another requirement was for the therapist really showing enthusiasm and knowledge in the new technology, because this would motivate participants to uptake the eHealth. But also, quite importantly, it was reported that when pre-existing good relationship existed between the therapist and participant, ideally before lockdown, this would be a facilitator for more effective use of eHealth during the lockdown. Some of the benefits of eHealth were the time efficiency of sessions, because obviously, you know, remote sessions did not require any travel to participants' homes. Also, compared to phone consultations, which was the other means of delivering praise during the lockdown, eHealth enhanced participants' motivation to keep active, because the participants were doing the exercises together with the therapists in real time, as you can see in the picture on the right-hand side. But also because of the basic requirement for caregivers to be present and act as facilitators, this boosted their dementia awareness, their knowledge about the condition, and overall their commitment to the study. Finally, the therapists reported that changing to a remote delivery enhanced their creativity to sort of come up with new innovative ways to keep the participants engaged in the process. There were also some challenges of eHealth. The first and major one was that users had poor IT skills. This was due to a generational issue, but also to cognitive impairment. And along the same lines, there was a lack of infrastructure and support for some users. For example, there was a lack of internet access, poor connection, no computer, or also in terms of living alone with nobody to support the participant. The therapist reported that some of their activities were difficult to be done through video consultation, particularly activities around risk assessment, progressing participants safely and confidently, but also in terminating report at the end of the 12-month enrollment. So this study has many limitations, including a small sample and a very time-bound the fact that it's a very time-bound study. Particularly, it was undertaken in very extraordinary circumstances. Nonetheless, we feel that there are important implications for future clinical practice. We found that delivering praise through eHealth was feasible and acceptable to most clients, caregivers, and therapists, but that digital means of delivering praise presented many limitations. The main one was the lack of digital literacy and access of clients. There have been attempts in developing dementia-friendly equipment and education, but there is still a need for service design and guidance of more dementia-friendly tele-rehabilitation. Traveling long distances or for a long time for face-to-face rehabilitation sessions is time-intensive. Therefore, tele-rehabilitation might be a way to make services more time-effective than face-to-face rehabilitation. But nonetheless, our participants reported that face-to-face was the preferred means of receiving the intervention. And also for the therapist, it was the better way for some of the therapy tasks, like the initial assessments of clients' progression, but also establishing and terminating support. So overall, our take-home message would be that video consultation may represent an acceptable adaptation in certain circumstances, but a hybrid approach where you mix face-to-face and tele-rehab would be a better balance between patients and service needs. So this is all. Thank you for your attention. I'll now be happy to take your questions.
Thanks, Claudio. It was an interesting presentation, and I think you also showed that it can really be effective in some way to have such an intervention, some tele-intervention, but it is also quite challenging to implement it in practice because of several reasons you mentioned. Do I understand well that this tele-rehab program, that it was really a one-to-one program that people had, and that it was not that they also could do videos with which they could train themselves? It was really face-to-face, online, seeing a therapist and practicing.
So the intended way was a face-to-face program delivered at home to the participants. So the therapist would go there and they would do the program together with the participants. When it was converted to remote delivery, it was still a face-to-face, obviously through remote means of delivery, but it was, yes, still tailored. That's the idea behind praise. So it was designed around the needs and aspirations of the participants, not group format. Sometimes the therapists could advise the participants to look at some videos online, for example, YouTube videos, if they were deemed to be suitable to the abilities of the participants, and of course, if they could watch them because they had the technology.
Okay, well, thank you very much.
Thank you.
I see no further questions yet from the audience, but maybe we will get some more. So then I would like to go to our next speaker, who is Reichold from Germany, and he will talk also about eHealth intervention in COVID times.
Okay, thank you, Franka. I hope you can see my PowerPoint presentation now. My name is Reichold, and I'm a research fellow at the Chair of Medical Informatics at Friedrich Alexander University Erlangen-Nürnberg in Germany. Today, I would like to show you a practical example of how the WordPress plugin technology can be used to disseminate eHealth interventions. Here you can see my agenda. First of all, I want to talk about the project Digitales Demenzregister Bayern, or in English, digital project Dementia Registry Bavaria, in which the eHealth intervention was developed. After that, I would like to present you our approach on how we want to contribute to a wider spread of eHealth interventions with the help of WordPress plugin technology. The benefits of eHealth interventions for people with dementia and their caregiving relatives have been demonstrated in several studies. In times of contact restrictions, digital solutions have become increasingly important, especially for people with dementia and their mostly elderly caregivers, which are at an increased risk for severe illness from COVID-19. With 50 million people affected worldwide, dementia is one of the major challenges the healthcare systems are facing. In Germany, 1.6 million people suffer from dementia. About 70% of the people with dementia in Germany live in their home environment, cared for by close relatives who often suffer a high caregiver burden and become the so-called invisible second patients. If you take a look in the literature, you can find many studies about eHealth interventions for dementia caregivers. 2019 at the Alzheimer Europe conference in Den Haag, I saw a slide that only 3% of dementia caregiving interventions move from research to practice. Only 3%, and we heard it before from Hannah. This means 97% of the interventions never were usable by most of the caregiving relatives. So there's an urgent need for improvement here. Here you can see the project Digital Dementia Registry Bavaria, or short DigiDem Bayern. The project is funded by the Bavarian Ministry of Health and Care and part of the Bavarian Dementia Strategy. The project is conceptualized for 5 years and based upon 2 different pillars. One pillar on the left is the establishment of a digital registry with the aim to collect data from people with dementia and their caregivers, with a 3-year follow-up. With the second pillar, we want directly contribute to the improvement of the care situation, and therefore we want to offer digital services for the people with dementia and their caring relatives. The objective of our study was to demonstrate an easy way how you can disseminate an eHealth intervention, which was developed in the context of a dementia research project. To bring science into practice, several requirements were placed on the development of the solution. Among others, these have been: first, the intervention is based on scientific findings. There are existing already many of digital offers and apps in practice that are not validated, and the effectiveness is unclear. Second one, it should not be a theoretical model. Instead, the method should be shown using a practical example. Third, the solution must be customizable and flexible so that you don't have to create a new program version every time you change a word in the text, for example. And last but not least, if other providers want to offer the solution, no programming knowledge should be required, for example, to perform a language adaptation or add even a new language. Based on the object and the requirements, we have developed a new eHealth intervention, say Dementia Caregiver Traffic Light, or as we say in German, Angehörigenampel. The Dementia Caregiver Traffic Light is based on a questionnaire with 10 questions about the caregiver burden. The measured physical and mental burden is presented after the questionnaire in the form of a traffic light. Furthermore, the caregiver receives recommendations based on his or her results. So he or she knows what to do in the next step to lower his or her burden. The short form of the burden scale of family caregivers from Professor Gresel et al. And the classification system for caregivers by Pendergrass et al. Are building the scientific basis for this intervention. The intervention was developed as a WordPress plugin in the scripting language PHP. And as you can see on the picture right, the intervention can be accessed on the DigiDem website. On this slide, I would like to give you a quick overview of the intervention. The caregiver starts by choosing the language he wants to do the burden assessment. After that, he gets a brief explanation about the assessment. There are 10 questions to which answers can be given with 4 predefined answer options. A total score is then calculated from the answers given, which can vary between 0 and 30 points. Depending on the result, the caregiver receives further recommendations to strengthen the physical and mental health. Besides the short version we see before, there is an extended version in form of a PDF, which you can print out and show to your doctor, for example. And the PDF on the right side, you can see the traffic light classification again, where the name of the intervention came from. It is recommended that the caregiver checks the burden at regular intervals. So the caregiver can get a reminder email to do the assessment again after 6 months. Finally, the caregiver can give us a feedback, for example, how assessed himself or whether he would recommend the intervention to other caregivers. To ensure a successful dissemination of the intervention, it must feature a high level of adaptability. Many interventions are often limited to only one language, which greatly restricts the user group. In the WordPress plugin, we developed the global settings such as a link to the privacy page, whether I want to display a feedback section or not, and all of the graphics can be adjusted. Also, all the text modules such as the questions, answers, results, and the recommendations can be modified. Even existing languages can be changed, deactivated, or completely new languages can be added. For an example, you could create Bavarian as a new language as shown in the screenshot on the right. Besides the high adaptability and to increase the dissemination, it was important that the requirements for an own installation are very low. All you need is a own WordPress installation. We have chosen WordPress as platform because it has low hardware requirements and requires hardly any special knowledge. Also, WordPress is the most widespread free content management system, so the likelihood is the greatest that there already exists a local installation. The WordPress plugin technology makes an installation on other websites very easy. You only have to upload a zip file in your WordPress environment and activate the plugin. Therefore, you can get the intervention as a zip file from us for free, along with instructions on how to customize the plugin to your individual requirements. For example, if you want to add your own new language. As a limitation of the WordPress plugin method, it can be seen that data privacy should be considered and corresponding protective measures must be taken into account during the development phase. For example, the email address for the reminder function is encrypted, stored in the database, and we are using the AES 256 standard. It is decrypted only for the mailing process and deleted afterwards. The problems that eHealth interventions do not move from science to practice have been addressed in recent studies, as we heard before. There are also first considerations which financial frameworks must be created to have a sustainable implementation. We believe that one of the easiest ways to bring an eHealth intervention to caregivers is to use websites they are familiar with. The focus on the development was on factors enabling a sustainable implementation and allowing a flexible adaptation to regional conditions. To minimize the barriers of implementation, it was ensured that the installation did not demand any major technical requirements in terms of software and hardware, and that country-specific adaptations, such as a language, were possible without any programming experience. So what are the next steps? On the one side, we received a request from the palliative care sector to extend the dementia traffic light for caregivers of palliative patients. Here we currently adapting the thresholds for the caregiver burden levels based on existing study data, and our project partner is working out the recommendations with an expert group. So currently we hope that traffic light for palliative caregivers will be published next year. Also, we have already disseminated the plugin to local dementia service provider in Germany. For example, you can see here the integration of the plugin on the website of a local service, social service provider called Centricum. The social service provider has integrated the traffic light himself on his website and has adapted it also, as you can see here on the right side, to locally available services. As you can see, you can also directly hyperlink to websites of the corresponding services in your local area. So if you want to implement the caregiver traffic light on your WordPress site, feel free to contact us. It's free, and we will send you the zip file and the manual to install it on your website. You can also find more details about the plugin in our open access application, or if you send us an email. So thank you very much for your attention. And if you want to get in touch, you can do it with the email you can see here on the slide. And now I will be available live for questions. Thank you very much.
Thank you, Michael, for this interesting presentation. Good that you thought of how we can do it as easy as possible with not too complicated programs. For service providers, I think it's not too complicated. Maybe for the family caregivers it is, or is it not for the family carers themselves?
No, it's for the service provider, and the caregivers can access it via the website of the local service providers.
Oh yeah,
So,
yeah, and also nice that you go international with them being available in different languages, indeed. So yeah, I did not see questions from the audience. I don't know if one of the other panelists maybe has a question for you. No, I don't see it either. Okay, then we go on with the next speaker. Who is Natalie Elliott from the United Kingdom, who will also talk about a pilot study, ask us about dementia, a pilot study in Wales. So please go ahead.
Thank you very much, Franka, for the introduction. Hello, everyone from Wales in the UK. My name's Natalie Elliott, and I'm going to be presenting this collaborative project that we've been running in Wales over the last sort of year to 18 months that we've called Ask Us About Dementia. And I'd just like to highlight that this is a project that's jointly run and managed with my colleague Rebecca Cicero, who unfortunately isn't able to be here with me today. And her background is she's an improvement and development manager at Social Care Wales. And we've also worked really closely with an organisation in Wales called Tech Cymru, who supported us with the technology and the evaluation of the project. So we go to the next slide, please. So the context to our project. First point, please. So early on, when the UK was first impacted by COVID-19, we were, like many of you, I'm sure, very concerned about the potential impact this was going to have on people living with dementia and their families. And we were thinking nationally as a group about things that we could do to try and support people as much as possible during these difficult times. Next point, please. We were also really concerned about the impact on our professional care staff, our workforce. For people living with dementia and their families, we learned very quickly that lots of services unfortunately had to be paused or withdrawn to keep people safe and to follow the guidance at that time around staying at home. And for our care staff, our professional workforce, they were under so much more pressure, working in stressful, sometimes distressing situations. And we were anticipating potentially as well a high turnover of staff in some of those settings, for example, our care homes, and potentially rapid recruitment of people back into those roles who may not have the time to have the level of training that we would normally like them to have in those positions. So we're thinking about both of those things and what could we do to help. Next point, please. And the other thing that we have in Wales is we acknowledge that unfortunately at the moment we have some excellent services and support for people in Wales, but it's not equitable. So it does depend a bit where you live, what's available locally. And with this project, we were really trying to think on a national scale, what can we offer to try and improve the equity of access for people living with dementia and their families on a national picture. So next slide. So the objectives that we created for this piece of work, the first one, please. So what we set out to do is to provide timely access to expert advice and signposting on dementia care using telehealth. And this was aimed at both family carers, so our unpaid care workforce, and also our workforce of professionals working in dementia care. Next point, please. My role is that I'm the National Allied Health Professions Lead for Dementia in Wales. And the Allied Health Professions in Wales cover 13 different professions. So I won't list them all now, but it includes groups like physiotherapy, occupational therapy, speech and language therapy, dietitians, podiatrists, and many others. And what we know is that, unfortunately, there is a lack of awareness in our colleagues and also in the public about our role and how we can help support people with dementia. And it can be difficult for people living with dementia and their families to access the expertise of these professions quickly and early in their journey of dementia. Next point, please. And we also set out to see what can we do to support some peer learning between health and social care practitioners with this service. Next point, please. So just a quick overview of our service design and how we developed our thinking. So if you'd like to bring the picture up for me, please. So briefly, this was very much an improvement project, and we started out by having lots of meetings and discussions with our stakeholders. So listening to what the issues were for people, understanding what was currently available in Wales, where the gaps were, not wanting to duplicate anything that was already on offer. And we very quickly learned that there's some excellent sort of telephone support services available to people from organisations like our Alzheimer Society. But they were telling us sometimes they don't, for the level of question that people might have, they don't always have the expertise to be able to support fully. And that in our local services, in our regions in health and social care, it can be quite hard to access some of the professions quickly. And there may not be, as I said, always everything available, depending where you live. So we were exploring as well technology. So what different ways could we support people? And we looked at models and other examples of things that were happening. And we learnt from colleagues in Scotland who had offered a service called Ask an Occupational Therapist using a technology system that we've ended up adopting in Wales. So we worked with our organisation Tech Cymru around the technology available to us and looked into developing our business plan and case for this project. We met with a number of partners and practitioners around our ideas for the service and talked to them about whether this was something that they could support. And we developed really clear structures. There was quite a bit of time spent upfront in making sure we had all the supporting documentation and procedures in place to be able to set this service up safely. And we followed a process of constant evaluation. So we've been checking in with all of our stakeholders and listening to the experiences of people who've accessed the service to make sure that where we can, we are improving. Next slide, please. So I'm not going to, in the time I have, be able to talk through this in any detail, but it's just to share a model of the service that we're delivering. And where somebody does need some advice and they book for a one-off telehealth video consultation with a couple of professionals that support our service. And we have a range of professionals available on our booking system that people can go on, have a read through a bio that says, hello, my name is, I can help you with, and select an appropriate appointment to speak to somebody. And we use a video consultation platform called Attend Anywhere and a booking system called Eventbrite, which you may be familiar with. We follow a coaching model, and that means that the caller is also seen as the expert, and that at the end of that conversation, they have a plan to go away and implement. And we are using tools then to evaluate that. So next slide, please. And if you could pull the first point up. Thank you. So key to the call management is that we are connecting people with specialists who have specific expertise in dementia care to provide advice and signposting. So we're not taking on duty of care. We're not replicating what would be provided longer term, perhaps, by the local services, but we're trying to provide very early support to questions that may be quite small, that we're encouraging people not to wait for a big problem, to come and talk to us, to get some advice, to hopefully reduce crises and problems that may develop. Next point, please. As I said earlier, we have 2 practitioners on each call, and we tried different models when we were starting the project. And what we found is having 2 practitioners with different but complementary skill sets has been really useful for the caller to be able to get a more holistic view over the issue that they're wanting to talk through. Next point, please. In Wales, we are a bilingual country, so we also offer the service in Welsh. Next point. And as I shared, we follow a coaching approach, so a model called the GROW model, which is a kind of stepped approach to make sure that we're supporting the caller and coming up with some actions at the end. We do offer the opportunity for a follow-up call. So if the person would like to book on another appointment to check in with us once they've had chance to explore those actions, we've had a small percentage of people that have chosen to do that, but many people feel, you know, skilled and able to go off and not need to come back. Equally, we've had some people who've decided they've really benefited from the service, and maybe another issue has come up with a different question, and they have booked on to speak to a different set of practitioners at a later date. Next slide, please. So in terms of the evaluation now, moving forward, we've looked at in what we've called phase 1 that ran from sort of September 2020 through to August. We had a total of, through to May 2021, we had a total of small numbers, so 57 bookings, and 42 of those attended, and 64% were family carers. So you can see it's been really beneficial for families to be able to access. But we've also had a large number of healthcare support workers booking. We've also had a couple of callers of people living with dementia themselves access the service, and we're keen to support that. Next slide, please. And if you could bring up the first points. Thank you. So we worked with Tech Cymru on an evaluation of what we called the first phase of this, pilot. And they did a mixture of mixed methods approach to using surveys at the end of calls, to speaking to people over the telephone for one-to-one interviews, and running some focus groups to evaluate the service. And what we learnt from both the callers and what we've called our pilot sites who signpost people to the service is that they all reported that they felt they had increased access to specialist dementia support, which is excellent. Next point. They really appreciated and valued the opportunity to speak to more than one specialist at the same time and get a holistic picture. Next slide. Next point. During the pandemic period, the fact that this was over telehealth meant that they felt there was a reduced infection risk, and this is something they really valued. Next point. And it was easier actually for our families and our paid workforce to schedule these appointments around their caring responsibilities. They didn't have to travel to speak to somebody. They could just follow an easy link to access a service online. Next point. And as part of this, it often we were able to avoid people needing to then have a face-to-face appointment or sit on a waiting list for the local care. Next slide, please. And in addition, I'd just like to read out quickly before I go on to the outcomes for the practitioners, a quote that we had. So one was, the practitioners took the call and both gave excellent advice, but also gave the carer time and space to ask some really important questions that she had not been able to ask other professionals who have been focused on their specific involvement rather than the whole situation. How wonderful is it to have experts available at the touch of a button? Thank you again for leading a fantastic service. So first point on this slide, please. So in terms of the experience of the practitioners on the service, we found that they also felt that there was an improvement in people being able to access their specialist advice and support. Next point. That there was a positive experience of the technology as well on both sides. Next point. And that they felt that there was an increased awareness across Wales on the roles of the allied health professions through this service. Next point. And one of the big things that we're really pleased about is that people fed back that they felt that they'd learnt from each other's roles. So there was more cross-disciplinary learning and working together. Next point. And that people felt they had the chance to sense check against each other. So this is the sort of thing we're doing in this part of Wales. Would you do something similar? And finally, we were supporting wider awareness of the different services available across Wales. Next slide. So we're now in what we're calling phase 2, and we've been able to receive funding to continue the service, which phase 2 started in October for a further 6 months with a larger scale evaluation. First point, please. So we've been including more practitioners, a greater range of skills in this phase 2, speaking to our pilot sites, what would they like to see? And one of the exciting additions we've had is a music therapist. Next point. We're increasing the access across Wales so that more areas are able to use the service. And next point. And we're looking at different systems that we can improve in terms of the technology so that people can book and access the service in different ways. And next point, also thinking about the accessibility for people around sort of the digital skills and technology. And finally, we'll be looking to explore during this phase funding options to hopefully roll this out as a more permanent service across Wales. Thank you. And my final slide is just a recognition of all of the people that are involved in this piece of work. So we have a number of practitioners, number of pilot sites and different organisations that are involved. So thank you to all of them. And that's the end of my session. Thank you.
Okay, thank you very much, Natalie, for this interesting service. I wonder how you get in touch with the practitioners, and do they get paid, or how do you get people motivated to join your service? And also, yeah, do others need to pay for the service, for instance?
So thank you for your question. So in the first phase, we didn't have the funding to pay our practitioners. So we were very fortunate that actually the practitioners were really keen to support the project, and they really understood the objectives that we were setting out to achieve. And they saw benefits for themselves. So in the fact that they could learn from each other and be part of this exciting project. So we were very lucky from that point of view. And I think the outcomes showed that people really did benefit from being involved. What we have done then, as we've developed our evidence for phase 2, is to be able to go to the Welsh Government and to get funding. So we are now able to pay practitioners to be for their time on the service. They are able to be really flexible in how much time they offer. Most people offer a couple of hours every month. So it's not a huge requirement, and they do that within their usual roles as agreed by their manager. And then the people who access the service, it's free for them. So we are offering this as a free service as part of our NHS Wales.
Okay, then I would like to thank all the speakers for their excellent presentations. I think it was very nice to see what is developed during COVID times. It also from some speakers what were challenges in implementing the services. And I think, yeah, some of those services you explained maybe also worthwhile in the post-COVID period. I don't know when that period will be, but hopefully sometimes. And then maybe, yeah, we have lessons learned from this period, and yeah, could go on with eHealth interventions. So many thanks to you and to Alzheimer Europe also for assisting in this symposium and hosting us. And I wish you a good next yeah, part of the closing ceremony, I think almost. But well, thanks for participating all.